Welcome to our lecture on quality improvement and post-cardiac arrest care. Today, we are going to explore how we can optimize resuscitation systems and manage patients effectively after they achieve a return of spontaneous circulation.
Healthcare delivery is complex, but we can break it down into a taxonomy of systems. It starts with structure, which includes the people and equipment. These feed into process, meaning our protocols and policies. Together, they create a system, like an organization's culture, which ultimately drives patient outcomes, such as safety and survival. All of this is wrapped in continuous quality improvement, meaning we constantly measure and adapt to do better.
Where a cardiac arrest happens completely changes the initial system of care. For out-of-hospital arrests, the patient relies heavily on the community, bystanders recognizing the emergency, starting CPR, and using an AED until EMS arrives. In contrast, in-hospital arrests rely on institutional surveillance to prevent the arrest and a rapid, multidisciplinary team response when it does happen. Both pathways eventually converge in the intensive care unit.
When a patient achieves return of spontaneous circulation, or ROSC, the battle is not over. They often develop a complex condition known as post-cardiac arrest syndrome. This involves brain injury from lack of oxygen, heart dysfunction, a systemic inflammatory response from ischemia and reperfusion, and whatever underlying disease caused the arrest in the first place. This syndrome plays a massive role in patient mortality, which is why specialized post-arrest care is so critical.
To manage these complex patients, we use the Adult Immediate Post-Cardiac Arrest Care algorithm. It provides a step-by-step framework starting the moment ROSC is achieved. The immediate priorities are optimizing the patient's airway and breathing, treating any low blood pressure, and getting a 12-lead ECG to check for a heart attack. Let's break these steps down. Step 2 focuses on the airway. While you might use 100% oxygen during the initial code, once the patient has a pulse, you must dial it back. We target an oxygen saturation of 94% or greater to avoid oxygen toxicity. Also, do not hyperventilate the patient. Squeezing the bag too fast increases pressure in the chest, which decreases blood return to the heart and lowers cardiac output. Stick to about 10 breaths per minute. To ensure we are ventilating correctly, we use quantitative waveform capnography. This measures the end-tidal CO2, the carbon dioxide exhaled at the end of a breath. A normal reading is between 35 and 40 millimeters of mercury. Not only does this confirm our endotracheal tube is actually in the trachea, but it also helps us monitor cardiac output and avoid hyperventilation. Next, we must ensure the brain and organs are getting enough blood. If the patient is hypotensive, meaning their systolic blood pressure drops below 90, or their mean arterial pressure is below 65, we need to act fast. We typically start with a fluid bolus of 1 to 2 liters of normal saline or lactated ringers. If fluids are not enough, we move on to vasopressor infusions to squeeze the blood vessels and support the heart. When choosing a vasopressor, you have a few options. Epinephrine and norepinephrine are typically dosed between 0.1 and 0.5 micrograms per kilogram per minute. Norepinephrine is a particularly potent vasoconstrictor, great for severe hypotension. Dopamine is another option, usually dosed at 5 to 10 micrograms per kilogram per minute. Whichever you choose, the goal is to titrate the drip until that systolic pressure is safely above 90. Because cardiovascular disease is the most common cause of cardiac arrest, getting a 12-lead ECG is a high priority. We are looking for a STEMI, an ST elevation myocardial infarction. If we see one, or highly suspect a heart attack, the patient needs immediate coronary reperfusion. This usually means rushing them to the cath lab for a PCI, or stent placement. And importantly, this can and should be done even if the patient is comatose. If the patient is not following verbal commands after ROSC, they are considered comatose, and we must protect their brain. We do this through targeted temperature management, or TTM. We cool the patient to a constant temperature between 32 and 36 degrees Celsius and keep them there for at least 24 hours. TTM is currently the only intervention proven to improve neurologic recovery after cardiac arrest.
A critical rule in post-arrest care is not to rush neurological prognostication. It is very difficult to predict brain recovery in the first few days. If a patient undergoes TTM, you must wait at least 72 hours after they have been warmed back to a normal temperature before making a formal prognosis. Sedation and paralytics can linger in the system and mimic brain death, so patience is absolutely vital.
Throughout the entire resuscitation and post-arrest phase, you must be a detective. We use the mnemonic of the H's and T's to remember the reversible causes of cardiac arrest. Is the patient hypovolemic? Are they acidotic?
Do they have a tension pneumothorax or a coronary thrombosis? Identifying and treating the root cause is the only way to prevent the patient from going right back into cardiac arrest.
To wrap up, successful resuscitation does not end with a pulse. It requires a continuous, integrated system of care. Remember to optimize oxygenation without hyperventilating, support blood pressure, hunt for heart attacks that need the cath lab, and protect the brain with targeted temperature management. By following these structured steps, we give our patients the absolute best chance at a meaningful recovery.